Ureteral fistula. Ureteral fistula have many causes. Congenital ureterorectal and ureterovaginal fistula are extremely rare. Acquired fistula, on the contrary, occur in any portion of the ureter, at the upper end after nephrectomy, especially if the ureter is actively tuberculous. In other parts of its course, cutaneous fistula form after the duct has been inadvertently divided during an abdominal operation or after rupture from stone, stricture, or other disease, such as tuberculosis and neoplasm, or from trauma or pressure of some intra-abdominal growth, usually of the uterus or ovary, or from injuries inflicted during labor. The essential cause of the persistence of fistula in all such cases is obstruction of the ureter, usually by stricture between the fistula and the bladder. If this obstruction is relieved, the fistula will heal. The discharge from the ureteral fistula is usually uropurulent, sometimes simply purulent, and rarely simply urinary. The presence of urine in the discharge may be taken as presumptive evidence that the fistulous ureter leads up to a functioning kidney. Yet the presence of urine does not prove a connection with the kidney, for the urine may regurgitate from the bladder through a ureteral fistula if the ureter is gravely diseased. Treatment. The treatment of cutaneous fistula is nephrectomy if the kidney has ceased to functionate, dilatation by ureteral catheter, or ureteral anastomosis if the kidney is worth saving, page 701. The treatment of ureterovaginal and ureterouterine fistula is no simple matter. The great variety of operations employed for its cure, the great proportion of failures after most of these, and the total absence of concerted surgical opinion upon the subject attest the complexity of the problem. Abdominal ureterocystoneostomy should be tried. Hysteroclysis and colpoclysis are operations of last resort. The functional result of including the uterus or the vagina in the urinary reservoir is anything but satisfactory. If all attempts at ureterovesical anastomosis fail and the opposite kidney is healthy, nephrectomy is preferable to colpoclysis.